Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you.
Y'all, we loved Katie so much. We had to have her back.
We
did not finish our conversation, and we want to keep asking questions.
There were just so many things that Katie Webster, who was with us in a prior episode on osteoporosis, brought up, and Amber and I said, okay, we have more questions.
We have more questions. Our minds are blown.
Our listeners are going to have more questions, and you're so fabulous and so knowledgeable.
Well, thank you.
Thanks for hanging out with us for a follow-up for
more
some
than you
frequently
bargained for.
asked. Yeah.
Well, I could talk about bones all day, so that's fine.
And our goal is to really generate conversation around osteoporosis, and I think everything you said in the prior episode generates that conversation. So let's do some follow-up on maybe a little FAQ, a little frequently asked questions.
Yeah.
And we'll just throw some stuff your way and stuff that we know our listeners are going to benefit from.
We talked about it very, very, very little about the calcium and vitamin D recommendations. We actually talked about kind of the pathophysiology, about how the calcium was taken out of the bone. But what would you recommend as a calcium and vitamin D supplement?
Yeah,
how much? How often?
I know. I was sitting here going, what milligram should I be taking?
I know, right? I was like 500 and,
The National Osteoporosis Foundation recommends that all people under the age of 50 get at least 1,000 milligrams of calcium a day through diet and supplements, and at least 800 units of vitamin D per day, which I personally think it should be a little bit more than that. So I tell everyone at least 1,000.
I agree, because we see a huge amount of vitamin D deficiency.
Absolutely. And I understand we've got some questions on that we're going to talk about, which is great. But over the age of 50, women, actually everyone, needs 1,200 milligrams of calcium a day. So it's only a little bit more, but it is important. And as I mentioned last episode, only 50% of people get enough calcium on a daily basis.
Well, if you think about, like, when I'm thinking about the bottles themselves, patients will often ask me, and I do give recommendations, but often they're doing one. They're not reading the back of the bottle, and they're actually supposed to be taking 2.
Right.
So you see often patients will say calcium, and I said 500 milligrams because that's pretty traditionally what we're seeing on bottles.
Yeah, 500 to 600.
Yeah.
When I talk to patients, we have a pretty in-depth discussion that covers not only diet but supplements. And I actually ask them to bring their bottles in with them because that is so common. People don't know what they're taking, or they think they're taking, the right amount, but they didn't see that the serving size on the bottle actually says 2 tablets instead of 1.
Yeah.
And so it's really important because, if half of us aren't getting enough for the day and a significant percentage think they're getting more than they are, there's a lot of room for improvement. So the first thing that I usually do is a diet survey, because the best calcium comes from food.
So much easier to absorb.
Absolutely. Yeah. And supplements definitely do have their place, but we shouldn't be overlooking diet as well. So I'll ask, how many cups of milk do you drink a day? Do you drink milk at all? I guess I should say.
You can ask me.
No. Do you eat cheese or yogurt? And we look at all of those things. And one trick that I teach my patients is that all of the percentages that you'll find on the nutrition facts on the back of any cheese package or yogurt is based on a recommended daily allowance of 1,000 milligrams a day. So it's actually pretty easy to figure out how much calcium you're getting from food, because if it's 20% of your calcium per serving, that's 200 milligrams. Just add a 0 and you know that that's 200 milligrams. And so we count up how much they're getting from their diet. And it's not just dairy, it's other things as well. Dark green veggies are a great source of calcium. Certain fatty and oily fishes like salmon and cod can be a great source of calcium. So we talk about all of that. And even with the preparation of vegetables, you can certainly cook all of the calcium out of your greens, and they'll be delicious, but they won't be, getting you that calcium. So we also talk about food preparation. And then once we get a good idea of how much calcium you're getting from your diet, then I talk about supplements. And it is important to look at those labels because Citracal, for example, is a great form of calcium. It's calcium citrate. It's very easily absorbed from the GI tract, and it's safe for people to take if they're taking certain medications for acid reflux, because that's another big thing, folks. Your other medications can have a significant impact on how well you're absorbing your calcium. Right. And there's a huge, very commonly used class of medications called proton pump inhibitors that will block the absorption of a lot of calcium supplements. So again, we talk about medications and how they can affect our bones and our ability to absorb calcium. But calcium citrate is a great form of calcium that can be absorbed even if you take Protonix, for example, for your acid reflux. But it's a 2-pill serving size. And so many people buy that bottle and they take one pill twice a day and they think they're doing something great, and they are. But they're not getting as much enough. Not great enough. They should actually be taking 2 in the morning and 2 in the evening to get that full 1,200 that they're trying to get. So after we talk about diets, we look at supplements. And it is also important to note in this conversation that we're not just talking about calcium. We're also talking about vitamin D, because vitamin D is an essential ingredient for calcium to be effectively absorbed by the body. And you cannot discuss one without discussing the other. It is so important. And most people can't get their vitamin D from food. Right. Because there's very little naturally occurring vitamin D in food. It is added to dairy products. So that's great. You get about 100 units of vitamin D per serving of dairy. And you can get some vitamin D from actually mushrooms. A lot of mushrooms are now fortified with vitamin D. But our most abundant naturally occurring source of vitamin D is sunlight. And so sun exposure, unprotected sun exposure, I should say, is also essential for generating enough vitamin D to absorb calcium, but most people have to take a supplement to get what they need.
And if you listen to other episodes, we have strongly encouraged you to not have unexposed sun
and
exposure.
it is a battle, and we do, dermatologists have done a great job of encouraging us all to wear sunscreen because it prevents skin cancer. But an SPF of 15 will block 90% of your body's ability to synthesize vitamin D.
Then tell us what vitamin D to take.
Yeah.
Okay. So,
vitamin D, we were talking a little bit offline about vitamin D, and there you can read so much on it. Certainly, there's a great deal of vitamin D deficiency.
Absolutely.
And the more you read, the more you realize what it does, and it does so much. Helps, during COVID, there was a lot of conversation about are people with vitamin D deficiency doing more poorly when they get COVID, because we believe that it really has a huge effect on your immune system. Muscles and muscle twitches and cramping. I've had so many patients. Vitamin D has an effect on processing your insulin and sugars. And diabetics will struggle keeping their sugars controlled when they're vitamin D deficient. Well, heart health, we could go on to probably every organ in your body.
Well, you really can. That is the truth, because almost every cell in our body has a receptor for the active form of vitamin D, which is a hormone. And so if we're not getting enough vitamin D on a daily basis, there are receptors in cells in our body that are going unfilled with this hormone that we need.
Yeah, I feel like it was named
it is
incorrectly.
Essential.
Because it is a hormone. It is not a vitamin.
Right. Yeah. But you can take it in supplement form. And that is, as I said before, what most people end up needing to do. I recommend across the board for everyone, whether I know your vitamin D level or not, a minimum of 1,000 international units per day.
And I think if you look at a lot of multivitamins, even a basic multivitamin, a good multivitamin will have 1,000 of vitamin D in it. So it's not that you have to run out and add vitamin D. If you're not so sure about your diet and you take a multivitamin to help fill the gaps, you may be getting enough D to hit that 1,000 a day in a multi.
And that's, again, why the labels are so important. But I will just a couple of tips for anyone who's going to the drugstore to buy plain old vitamin D all by itself. I would tell people to make sure that they know what dose they're getting, because vitamin D dosages over the counter range from 400 units, which is quite frankly spitting in the wind as far as I'm concerned, all the way up to 10,000 units, which most people don't need on a daily basis.
And vitamin D is one of those fat soluble vitamins, which means our body will not just flush out the excess. So you can get too much. You can get too much, and that's important. Although it's much harder to get too much.
We rarely see it.
Yes, we do very rarely see it.
I think 2 people, I order a lot of vitamin D levels. I think 2 people in 20 years were over the 100 cutoff.
It's been about the same with me, but when you go to the drugstore, you'll want to pay attention to the dose, but also the type of supplement you're buying, because soft gels are absorbed much better than tablets. So try to avoid buying vitamin D tablets if you can. And I know that seems like a tiny thing, but
it doesn't
but
really
the soft
do
gels
much
are better
good if it just goes straight through you and into the toilet.
Correct.
Yeah.
Yes. So, and it's also important when we're talking about bone health. This is one of the things that we can measure is vitamin D levels. We can draw blood and know what your vitamin D level is. And if it's below the threshold that we, call deficiency, we treat it with a prescription, and we can actually correct low vitamin D levels. So it is an important screening test when you're evaluating someone's bone health, because if their vitamin D levels are low, they're not absorbing calcium effectively, and you can throw as many supplements as you want at them, but they're not going to be absorbed. So this is extremely important. And anyone who's been treated for vitamin D deficiency also needs more vitamin D for maintenance. Once your deficiency is corrected, it's recommended to up your daily intake to 2,000 units a day after the deficiency is corrected. So.
Yeah, and a lot of times people will be on prescription and then they stop the prescription and we test them again in a year and they're right back down.
I call it the vitamin D roller coaster.
Yes, and so I do like to emphasize to my patients that you no longer need to take the prescription. You're in a normal range. You will not stay in that normal range if you're not taking a daily supplement. And
Correct.
So please go ahead and take 2,000 of over-the-counter D to maintain your vitamin D levels, but we'll continue to watch it and we'll see it drop if they're not taking it. Absolutely. So other kind of frequently asked question that people might be wondering a little bit more after our other conversations, who should be getting a DEXA scan?
That's a really good question. In my practice, all women who were at least 5 years out from menopause got a DEXA. And the average age of menopause in the United States is 51. So we're looking at about 55, between the ages of 55 and 60 for most of these women. Now, if you're 55 and still having periods, you don't need a DEXA. But getting a DEXA within the first 5 years of the menopausal transition really allows us to get a great baseline and identify bone loss before it becomes osteoporosis. Right. And that is really where the DEXA is underutilized. Most people get a DEXA after they have a fracture. But if you can get a DEXA done before the fracture occurs, you can know what needs to be done and act on it so that you don't get osteoporosis in the future. So women should have, in my practice, always, within 5 years of the menopausal transition, and then all men over the age of 75 should have a DEXA scan. Getting it covered by insurance is always a little bit tricky because Medicare just doesn't like to pay for DEXAs in men. But it is recommended that all men also have a DEXA by the age of 75 because osteoporosis affects men as well.
Yeah, and which I mentioned to you guys kind of offline, and Shelly knows this, but my grandfather had a fracture and he fell August 3rd. And died September 3rd because he had complications from the back surgery from a fall. He had osteoporosis. He was 85. I was pretty well versed on his medical health, and I'm pretty sure he never had a DEXA.
Yeah, Probably not. And I will say that, we have different organizations in medicine, and anyone who's ever seen more than one doctor knows that not all doctors agree on everything. And so the United States Preventive Task Force, USTSPF, we frequently use to tell us what preventive recommendations should we be doing.
And it's very vague, and they're sort of like, have a conversation with men, but there's not a real clear recommendation to get DEXAs on men under that recommending society. Then, of course, it's going to be different under Osteoporosis Foundation and people who really take a stronger look at screening for osteoporosis have the recommendation for men getting DEXA scans over age 75. And
Yes.
and we started to I was not aggressive on getting men DEXA scans until I became more well informed in osteoporosis. And so a lot of my men now in their wellness visits, I'm getting set up for DEXAs, and the amount of osteopenia and osteoporosis that I'm catching is quite high.
Yes.
And I'm hoping that this is our ability to prevent those fractures and the negative outcomes like happened with Amber's grandpa. On the bone densities, I'm kind of perimenopausal myself, and the recommendations are 5 years post-menopause. And based on those recommendations is whether insurance is going to pay for it or not. And so, of course, we sit within the recommendations because there's research to support this. But I myself want to know what my bone density is around my time of menopause, because there are things that I may do in my perimenopausal state that change if I have a low bone density.
Right.
You mentioned in our prior episode about estrogen drops in perimenopause and how we get a rapid loss of bone in that perimenopausal state.
Right. About up to 10 to 12% of
So
bone loss.
I
in
want
that
to
year.
know, what is my bone density now? Because if I'm perimenopausal and my estrogen is dropping and my bone density is already at an osteopenia, I may be more likely to move into hormone replacement and help give myself a little estrogen to help prevent osteoporosis. Or the progression to osteoporosis. I will say, for those of you who are seeing someone and you want to be more aggressive on this, paying cash for a bone density is not typically a real expensive endeavor.
No.
And so I do think that if you are told, well, no, your insurance won't pay for it because you're not 5 years post-menopause, or what the other recommendations might be, you can call around to imaging centers in your area. We offer cash bone densities as well. And typically it's, $129, I think, is the national average for that. And you may be able to, if you're paying cash at the time, negotiate that down.
Right.
So I wouldn't say take it off the table.
No.
Can you talk to us a little bit more about hormone replacement therapy and osteoporosis and hormone replacement therapy kind of in general? Because people may be on that fence of having a little bit of symptoms. I don't really think I want to do hormones. I've heard horrible things about it. Everyone in my family has the hunched over back, or I know grandma and mom have both had broken bones. How should that weigh in for us during these perimenopausal decision-making on hormone replacement therapy?
Well, it's a really important discussion, and the North American Menopause Society actually carves out a place for hormone replacement therapy with bone health. If a person needs it for, the symptoms of perimenopause or menopause, so the hot flashes, the night sweats, difficulty sleeping, mood swings, all of those.
The fact that your husband's breathing way too loud.
Exactly. All of those things. There is a place for hormone replacement therapy where we can also get the double benefit of bone protection. You may remember from my last episode that I talked about how estrogen is one of the primary mediators of bone turnover in women, and that our bones are living tissue, and that, like all living tissue, old bone has to be removed and new bone built for our skeletons to stay healthy. Estrogen helps balance that process in premenopausal women. So the presence of normal levels of estrogen in our body helps keep our bone density balanced from about the age of 25 to 45 or 50. And as hormone levels start to fluctuate, women can start experiencing what we call the vasomotor symptoms of menopause. So perimenopause is that fun time of our lives that can last up to 10 years where we're still having periods and our bodies are still producing hormones, but the hormone levels start to become kind of wacky and not producing as much estrogen from one day to the next even. And that is when we can get into that time of life, that transition where we're feeling a lot of the symptoms of menopause. Our periods might be becoming irregular. You can bleed more heavily or skip periods or have more than one period a month, and it can be all over the place for years, even up till menopause. And hormone replacement therapy in that time frame can actually give a lot of benefit, not only to improving quality of life for women who are perimenopausal, but also to help protect the bones during this transition. Because if you're taking hormone replacement therapy at the menopausal transition, you're not going to experience that dramatic bone loss, at the time of menopause. You're going to preserve what you had prior to menopause for as long as you remain on those hormones. So hormone replacement therapy, it does have its place when we talk about bone health. It is not recommended to start hormones just for bone health. The benefits are not considered to outweigh the risks when we're talking about bone health alone. But so many women experience these changes to their hormones, and it affects their quality of life. And the fact is that hormone replacement therapy is not as scary and bad as it's been made out to be for the last 15 or so years. It's a lot safer than we thought it was 10 years ago. And really more women are candidates for hormone replacement therapy than, we've been realizing over the last decade or so.
And the silent suffering is so unnecessary.
And absolutely. And the truth is that without the presence of a gene mutation that significantly increases your risk of gynecologic cancer, so breast or ovarian cancer, without one of those gene mutations, most women can take hormone replacement therapy safely for years. It's always going to be a discussion of whether or not it's needed, going forward after the menopause transition. But it is not the villain that it has been made out to be. The other thing, though, that I think a lot of providers don't pick up on that's really important with hormone replacement therapy and bones is that if one of your patients decides to stop taking hormone replacement therapy for whatever reason, be it that they had a blood clot or a concerning mammogram result, whatever that reason may be, that period of intense bone loss that they were able to skip over at the menopausal transition is going to happen when they stop taking their hormones. So it's actually recommended to make sure and that you get a bone density scan in anyone who has stopped hormone replacement therapy within that 12-month span so that you can assess for that loss.
Super important to tell your physician that you've stopped taking that medication so that they can get you a bone density scan. So we've mentioned a little bit more about DEXAs, and we've mentioned a little bit more about hormones and calcium and vitamin D.
She talked briefly last time about the exercise stuff, about weight-bearing stuff. So just to say that again, like you mentioned in the previous episode, like that's a huge thing. What are the risk factors? So I know not exercising, because that's important, not taking calcium and vitamin D, not obesity. Is that a risk factor?
Actually, no.
Okay.
Obesity is not as much of a risk factor for bone health as a sedentary lifestyle is. Because actually obese people carry more weight around. They
have to have stronger bones.
They have to have stronger bones because they're carrying more weight. But some of the other risk factors for osteopenia and osteoporosis are things like smoking, excess alcohol intake. 3 or more alcoholic drinks on a daily basis is harmful to bones. Certain medications can be harmful to bones. I mentioned that proton pump inhibitors, acid reflux medications.
Omeprazole, pantoprazole, Nexiums. Those are a lot of people take those, and they take them for long periods of time, and it does affect your bone health.
But it's not just proton pump inhibitors. There are a lot of other medications that can adversely affect bone. Insulin, diabetics who require insulin are at risk for more accelerated bone loss. Thyroid medication can cause bone loss if it's given in excessive amounts. So if you're taking thyroid medication, it's always important to get your follow-up labs to make sure you're still on the correct dose.
Steroids,
corticosteroids are the number one. Really, prednisone and other corticosteroids are strongly associated with bone loss. But the good news is that most providers who prescribe chronic steroid therapy are aware of that fact. And so those patients don't tend to...
Inhaled steroids for people who have had asthma for a long time. Inhaled steroids aren't getting into your bloodstream at the amount of the orals, but it is, if you've had to use that because you've had asthma your whole life, it will increase your risk.
It will.
Bone density
And
issues.
much more than we previously understood, because that's a new finding that's probably only 6 or 7 years old, that the inhaled steroids, so your inhalers, your Advair or different steroid containing asthma inhalers can affect bone loss as well. So,
and I think family history is an important one.
Family history is huge. And the truth of the matter is, while we talk about all these lifestyle things that are really important, 70% of your risk of osteoporosis is based on genetics.
Yeah. And I love to ask people, like, does anyone in your family have osteoporosis? And I think we in healthcare think that this is the Thanksgiving conversation. Who at the table has osteoporosis? However, it's really not. And so I think if you recognize that people have had fractures in your family, if you recognize that there's the kyphosis that happens with osteoporosis.
The little old lady who bends over and can't stand up straight.
Yes.
That's not bad posture.
The loss of height, where grandma used to be so much taller. Grandpa used to be so much taller. And so those are things that you can assume that your family has some osteoporosis if that's what your family looks like.
Absolutely.
If you're a family of small, thin, Caucasian or Asian, then there is likely more risk of osteoporosis with that as well.
Absolutely.
Yeah, I think any of those risk factors should have you having a discussion with your provider to be more aggressive in the screenings.
Absolutely. And it's up to us as providers to ask the right questions too, because while we may not always be aware of a family history of osteoporosis, we can almost certainly tell you that grandma broke her hip.
Yeah.
And it's, so asking the right questions is something that I've learned over the years is really helpful.
Yeah.
Has anyone in your house ever broken their spine or their hip, versus, because we know that, as we talked about last episode, osteoporosis is one of the most underdiagnosed and undertreated chronic health conditions in the world.
Yes.
So, so they may not know that word, but a hip fracture is certainly a big red flag that needs to signal, further investigation and counseling is probably needed.
And I think being aware of that loss of height as we age is also impactful. And when we were starting our osteoporosis and bone health clinic, we realized that our medical assistants in their busy workflow are getting a weight, but they're not measuring people at every visit for their height. And we said at least every single annual wellness, we want an accurate measurement of height so that we can start tracking. We look at weight really aggressively. We need to look at height just as aggressively so that we can recognize you are shorter than you used to be. We need to be aggressive to make sure we're not missing something.
Absolutely. Well, any height loss of greater than an inch that's measured in a healthcare facility should be grounds for a DEXA all by itself.
That's huge. That's really good to know.
It is.
That's really good to know.
So.
Well, I think it's fabulous that we have been able to stimulate so much conversation around osteoporosis. It's just something we don't talk about enough. And Katie, thank you for the work you're doing here, and thanks for all of your support that you've been giving us.
Absolutely.
And we certainly, I like to say every day when I leave for work, I have this lofty sense of self-importance, and I say to my husband and son, I'm going to save lives. And truly we are saving lives by preventing these fractures.
And helping preserve quality of life, because even if a fracture doesn't cause, a complication that leads to death, it can still have a significant impact on quality of life. And that's really what it's all about, is maintaining independence and being able to be functional and participate in
your family's life,
in your family's life and in your community. So It's really important.
Thank you so much. We hope you all have learned some more about osteoporosis today. Thank you so much for joining us.
We like to end you on a good note, so here's today's Tell Me Something Good. Something good is sunshine. The way that the sun makes you feel when it just warms you when you go outside. So enjoy some sunshine, wear your SPF so that nothing bad can come of it, but sit outside and enjoy the sun. Thank you for joining us today, and until next time, take care of yourself.